Hi, everybody. My name is Gaurav Khatri, and I'm from UT Southwestern Medical Center in Dallas, Texas. I'd like to thank you all for attending today and appreciate the invitation. Thank you especially to Dr. Rania and Dr. Fauzi for inviting me for this talk, and I apologize that I'm not able to be there in person. I'll be talking today about pelvic pain. I have no pertinent financial disclosures. So the objectives of today's talk are to discuss pelvic pain etiologies, as well as imaging of pelvic pain. I'll specifically talk about endometriosis, as well as some neurogenic pain in addition to some other etiologies for chronic pelvic pain. So as you can see, there's a number of etiologies for pelvic pain. We're going to focus mostly on the chronic pelvic pain etiologies. And chronic pelvic pain is defined as continuous or intermittent pain lasting 6 months or longer. So neoplastic etiologies aside, we'll focus today on non-neoplastic etiologies. And these can be thought of as etiologies pertaining to pelvic organs or the pelvic floor or neuromuscular conditions. So within the pelvic organs, we can have gynecologic conditions or other non-gynecologic conditions. In the pelvic floor, you can have pelvic floor prolapse, constipation, pain related to mesh or slings, and then neurogenic pain. So today we'll be focusing mostly on endometriosis as well as some of these pelvic floor and neurogenic pain. Pelvic floor pain because of mesh and slings, I will focus in the next talk. So our imaging technique on MRI for pelvis imaging in patients with chronic pelvic pain includes triplanar 2D T2 weighted images. We do T1 in phase and out of phase images, as well as pre-contrast and post-contrast images, and then diffusion imaging is optional. Importantly, if you're imaging a patient with suspected endometriosis, you may benefit from using vaginal gel, as this distends up the posterior fornix of the vagina. That's a common place for a subtle deposit of endometriosis. So what is pelvic endometriosis? So pelvic endometriosis is defined as implantation of endometrial glands outside the endometrial cavity. This affects up to 44% of reproductive age women. It can be seen in up to 81% of patients with adenomyosis. Patients may present with dysmenorrhea, dyspareunia, infertility, urine bleeding, and potentially urinary symptoms if the bladder is involved. There are three main types of lesions of endometriosis: ovarian endometriomas, superficial endometriotic implants, as well as deep infiltrating endometriosis. The superficial endometrial implants are not visible on imaging, so we'll be focusing on ovarian endometriomas and deep infiltrating endometriosis. So, ovarian endometriomas are cystic lesions. These are typically very high signal intensity on T1 weighted images. They are light bulb bright, as you can see here, and they exhibit a phenomenon called T2 shading. What this means is that the T2 signal intensity within the endometrioma is going to be lower signal intensity than simple fluid. So it's a little bit darker than you would expect CSF or urine in the bladder. Typically, they have this gray signal intensity on T2, despite having this very bright signal intensity on T1. They may or may not have this layering effect because of chronic hemorrhage. Here's another patient with an endometrioma, pretty large endometrioma on the right. Again, you can see this very bright light bulb T1, bright signal intensity that's very homogeneous. And on T2, it's kind of more gray. It's lower signal intensity than the adjacent urine in the bladder. This is T2 shading. This appearance is very specific for endometriomas. So these are typically cystic. So you can see here, this is that endometrioma I showed you earlier. On the left is a T1 weighted image pre-contrast. On your right is a subtraction post-contrast image, shows no enhancement within the center of the lesion. This is a cystic lesion. But these can restrict on diffusion images. So here you can see this large endometrioma on the right shows high signal on the diffusion weighted image and low signal on ADC. So this is truly restricting. And that happens because of chronic hemorrhage. So when you have a lesion that's bright on T1 weighted images, you want to think of a differential, and differential includes hemorrhagic ovarian cyst, ovarian teratoma or dermoid, as well as potentially some cystic ovarian neoplasms that may be high signal intensity on T1 weighted images. So How do you differentiate endometrioma from hemorrhagic cyst? In general, endometrioma tends to be higher signal intensity on T1 compared to hemorrhagic cyst because endometrioma is more homogeneous and light bulb bright. On T2, endometrioma tends to be lower signal intensity than hemorrhagic cyst. So these are general guidelines to look for. And that's because of the higher protein content and viscosity of fluid within an endometrioma. So here is a patient with a hemorrhagic cyst. You can see it's bright on T1, but not as bright as some of the prior endometriomas I showed you. And it's slightly dark on T2, dark, but almost as bright as fluid would be. Now, in comparison, here's an endometrioma. So this endometrioma is dark on T2, very light bulb bright and homogeneous on T1. And here's also a similar appearance of endometrioma in the same patient on the left with T2 shading. So this patient has bilateral endometriomas, which is very specific. Again, when you see bilateral lesions that are bright on T1 and dark on T2, you should be thinking about endometriosis or endometriomas. So here's a patient showing on the top row a lesion that's dark on T2, bright on T1, no enhancement. So it's a cystic lesion. On the left, same thing, T2 shading, very bright, homogeneous light bulb bright on T1, no enhancement centrally. So this is also a lesion with cystic appearance. These are both endometriomas, and you can be especially sure given the bilateral disease here. Now, you can have endometriomas, but you can also have endometriosis. One of the signs of endometriosis in this particular patient with bilateral endometriomas is that the ovaries are displaced medially. Now, I'm sure you've heard of the kissing ovary sign, which is where the ovaries are touching in the midline. Sometimes they're not touching, but they're just medially displaced, and they may be tethered to the back of the uterus like they are here. These are the medialized stuck ovaries, and to me, it almost looks like a Mickey Mouse, with this being the face and these being the ears. And then this is another example of stuck ovaries, which are medially displaced, but not quite kissing ovaries. Here's another lesion that is bright on T1 weighted images. It's also bright on T2. When we look on the in-phase image here in the center top row, there's evidence of dropout. So there's some intracellular lipid in this lesion. On the bottom row middle image, you also have a T2 fat suppressed image showing dropout there. So there is both intracellular lipid as well as macroscopic fat in here. The pre and post contrast images here on the right show no enhancement. So this is an ovarian dermoid. So it's important to look for the fat to make sure you don't confuse a fat-containing lesion for an endometrioma. All right, moving on to deep infiltrating endometriosis. So these are extra ovarian deposits of endometriosis. They are sometimes round or can appear as stellate plaques. They cause a lot of fibrotic reaction, which is typically low signal intensity on T2 weighted images. They may have foci of high signal intensity on T1 owing to the chronic hemorrhage in there. So here, as you can see, in this patient on the T2 weighted images, the red arrow on the left is pointing to ovarian endometrioma, which is also very bright on the pre-contrast T1, as you can see on your right. And then behind the uterus is this triangular dark T2 plaque-like structure, which is causing this anterior tethering of the rectum. This is endometriosis. This is an implant of endometriosis, and this is a plaque-like appearance there. And you can see tiny subtle foci of bright T1 as well, which, as I mentioned, is very common in these endometriotic plaques. So there's a series of papers in abdominal radiology in 2020, which is published by the endometriosis DFP of the Society of Abdominal Radiology. I highly encourage you to go read those papers if you're interested. And I've got a couple of schematics and tables and images from a series of papers from that special issue in radiographics. So it's important to know where deep infiltrating endometriosis lives. You really want to look at the anterior compartment, deep middle compartment, as well as the posterior compartment of the pelvis, and look for plaques of endometriosis in all of these locations. Here's a patient with a large plaque and mass along the posterior surface of the uterus. The red arrow is pointing to a plaque that's seen at the torus uterinus. And then there's infiltration along the posterior surface of the uterus from outside in. So these plaques can actually invade the uterus as well. And then, as I mentioned earlier, some of the other signs to look for are the adhesions, tethering. The uterus may be anti or retroverted depending on where the plaque is causing the fibrosis. The ovaries may be medialized. You can get hydrosalpinx and specifically hematosalpinx, which is a more specific sign for endometriosis. As I mentioned, look in the anterior, middle, and posterior compartments, and then there may be associated uterine adenomyosis. Here's a patient with hematosalpinx. You can see this tubular structure that's very, very bright on T1, and it's got this slightly darker signal on T2. This is a good appearance for hematosalpinx, but what else do we see? This red arrow is pointing to very dark T2 plaque that's causing tethering of this hematosalpinx to the rectum. If we look at this on a different view, on the sagittal view, you can see this is large plaque along the posterior surface of the uterus, and it's actually invading the anterior rectal wall. Along the more deeper portions, it's bright on T2 because that's the elevation and inflammation of the rectal mucosa. And then the more superficial portion invading the rectum, you can see is actually dark on T2. That's the fibrosis elicited by the endometriosis. And then you can see on T2 axial as well, this triangular area that's invading the anterior rectal wall and causing tethering, and it's got some progressive enhancement on delayed post-contrast images. This is a pretty classic appearance for ovarian endometriosis involving the anterior rectal wall. It can mimic what's called a mushroom cap sign, and it's called that because the undersurface is dark, just like the undersurface of a mushroom, and the upper portion is bright, just like the top of the mushroom here. So this is a mushroom cap sign. Always look for this, as this is very important for management when they're going for surgical resection of endometriosis. Here's another patient with bilateral endometriomas, very bright on T1, not quite as bright on T2, and also has hematosalpinx here on the left, which is a very specific sign for endometriosis. Here's a patient with anterior compartment involvement. There's this big mass along the posterior bladder dome between the uterus and the bladder. You can see it on this sagittal image. You can see it well on the coronal image. It's predominantly dark on T2, but it's got these tiny bright foci on T2 as well, which are corresponding to the endometriotic glands. Here you can see it on the coronal T2 as well. And then you see these punctate foci of bright T1 on the pre-contrast images, and the endometriosis, the plaque, demonstrates progressive enhancement, as is classic for endometriosis. Also important, especially in patients who have had prior C-section, to look for endometriosis in the abdominal wall along the C-section scar. You can see here a similar appearance as on the prior study, except this is in the abdominal wall. This dark T2 area with punctate foci of bright T2 as well. And on T1 pre-contrast, it's got these punctate foci of bright T1 with progressive enhancement. Again, classic appearance here for endometriosis. This is along a C-section scar. Now, rarely, endometriosis can undergo malignant transformation. Thankfully, it's not very common. It happens about 2.5% of the time. These are typically clear cells or endometrioid carcinomas. Risk factors include older patients, larger multiloculated lesions, or lesions with solid components. So let's look here. This is from the literature. A large cystic lesion that's predominantly high signal intensity on T2, but there is this more nodular area of low signal intensity on T2. And then if we look on the pre-contrast T1, majority of the lesion is bright. However, there are these nodular areas along the wall that are dark on pre-contrast T1, and then they disappear on this post-contrast image, and the subtraction image confirms enhancement. So this is solid tissue within the endometrioma. Should really be worried here about malignancy within the endometrioma. And then vaginal gel has been shown to be helpful for evaluation of endometriosis. For example, here, this arrow is pointing to the posterior fornix, which is not distending after installation of vaginal gel, and that's because of this endometriotic plaque here obliterating the posterior fornix. And more subtle, similar deformity here on the left and on the right as well, where you don't see that sharp posterior fornix. It's kind of blunted. And this is because of plaque involving the posterior fornix of the vagina. Now, moving on to pelvic floor ultrasound or pelvic ultrasound for endometriosis. This may be something that you are doing at your institution. We're about to implement this at ours. Most of the images and schematics I have here, again, are from Abdominal Radiology special issue on endometriosis from 2020. So this is showing the schematics along the top are showing the transducer position for evaluation of endometriosis. This image here is showing a retroflex uterus and the rectum, and you can see tethering of the rectum to the retroflex uterus by this hypoechoic plaque here. This is also a patient with endometriosis, and what we're showing here is the uterus and the right ovaries along the posterior surface of the uterus with medial displacement and touching. So this is the kissing ovary sign on ultrasound. This is a patient with a sliding sign. What they do is they push on the uterus, and the uterus and bowel and pelvic structure should be moving independent of each other. So if you play this video, you can see how the uterus is free from the rest of the pelvis, and it's moving separately from the bowel posteriorly. They're moving in opposite directions. However, if you look at this case, the uterus is not moving in the opposite direction from the tissues posterior to it. That's because it's tethered to it from pelvic endometriosis. So this is a sliding sign showing absence of independent motion of the uterus from the bowel because of endometriosis. Now, endometriosis can result in a neuropathy. It's rare, but it can be clinically significant. So it's really important to know the anatomy of the lumbar and sacral plexus. Here is just an example of the femoral nerves between the psoas muscle and the iliacus muscle on either side. These long arrows are pointing to the femoral nerves. These cases here were given to me by our chief of musculoskeletal radiology, Dr. Chabra. One of his specialties is MR neurography. So this is a patient where you see the right femoral nerve is asymmetrically enlarged and brighter than the left femoral nerve. And on the pre-contrast T1, you see this asymmetric soft tissue here on the right side from endometriosis. This reconstruction nicely shows the enlarged right femoral nerve. This patient had right femoral neuropathy, and you can see some muscle denervation as well in the thigh. Different patient showing, again, asymmetrically enlarged nerve sitting atop the iliacus muscle here on the right, as you can see going up on the right side. It's asymmetrically enlarged and bright on the right compared to the left where you don't see it. This is right iliohypogastric nerve inflammation, also because of endometriosis in this patient. Neurogenic pelvic pain can be caused by other etiologies such as prior surgery, trauma, infection, lesions, or compression or entrapment syndromes. What you're looking for is enlarged size of the nerve and high signal intensity on T2 and diffusion-weighted images. This is a patient with prior pelvic mesh. You can see some scarring in Alcock's canal on the left with the yellow arrow. The green arrow is showing the nerve, but distal to the area of entrapment. You can see in the red arrow on the bottom left here showing enlarged nerve with high signal intensity on diffusion because of nerve entrapment. This is the left pudendal nerve, which is entrapped in Alcock's canal because of scarring. Different patient here. This is the perineal and hemorrhoidal branch of the pudendal nerve that's entrapped. You can see the nerve is larger than we typically see on both sides, especially on the right. On the diffusion image, you see it much better than the left side. It's asymmetric because of entrapment. Other causes of chronic pelvic pain include adenomyosis. I'm just going to go through this quickly. Fibroids, which can undergo acute degeneration. Pelvic congestion syndrome, where you see enlarged vessels in the pelvis, dilated ovarian vein, and reversal of flow in the ovarian vein as well. Peritoneal inclusion cyst, which can be quite large. In this particular case, the peritoneal inclusion cyst actually was causing prolapse. That's a suspected rectocele or enterocele, but ended up being a large peritoneal inclusion cyst causing prolapse. And then you could have a variety of reasons for chronic pelvic infection or inflammation. Here you see an infected or chronically inflamed urethral diverticulum. You could have postoperative complication or musculoskeletal pain. So to summarize, we talked about endometriosis. We talked about the different types of endometriosis lesions. We talked about the 3 compartments. We talked about neurogenic pain, looking for the high signal intensity and enlargement of the nerve. And then we talked about briefly other causes of chronic pelvic pain, including adenomyosis, fibroids, inclusion cysts, pelvic congestion, and infection or inflammation. Thank you so much for your attention. I appreciate your time.
Are there any questions to Professor Gaurav? Hello, Gaurav.
Hi. Nice seeing you. We miss you over here, actually.
Are there any questions about the nice talk?
Yes, please. Gaurav, can you open the mic, please? You are on mute.
Yes. Hi. Can you all hear me?
Okay. Thank you very much. Okay, I have a question. How frequent do you see pudendal nerve entrapment syndrome in patients with pelvic floor dysfunction?
Yeah, great question. I don't think we see it as often in de novo pelvic floor dysfunction, but we have seen a few cases of it in patients after surgery or scarring or after trauma. It's hard to note the denominator and the true prevalence of it because there's so many patients out there, I think, with undiagnosed cause for the pelvic pain. And I suspect many of them may have nerve injury, such as pudendal nerve injury.
Dr. Amal, I think you have a lot of patients with pudendal neuralgia, yes? What's the most common that you use for them?
Post-surgical.
Post-surgical, you see most
Trauma
patients
from
post-surgical.
birth
Okay.
and adhesions followed it.
With adhesion of it.
Yeah.
And you relieve the pain with radiofrequency or with manual therapy or what?
Different kind, electrical stimulation, also osteopathy, also sometimes radiofrequency used for some cases, according to the patient and the evaluation of the patient.
Okay. But it's common, Gaurav, yes? You see many of them? Okay. Dr. Abdrabbo, what's your comment about the pudendal neuralgia because it is a hot topic right now?
Actually, Dr. Rani, in the last 10 years, I saw only one case. Only one. And we treated this patient with pudendal nerve release. And there is, from the escurectal fossa by adhesiolysis, yes.
Okay, now we are moving to the next topic.